everyone, and welcome to Echo HBV. Thank you so much for joining us. My name is Rachel Deere. I'm your facilitator. I'm with DKB Med. I'm joined by my colleagues Faith and Jill. You will see they have the same virtual background, so it's easy to spot them. We also have our wonderful hub faculty, Dr. Calvin Pan, who is waving right now. So Dr. Pan, thank you so much for joining. We've got some folks trickling in, so we're going to begin very shortly. Just want to give them the opportunity to join. And it's so great to see so many of your faces. We really want this to be as interactive as possible. And excuse my voice, allergies, I'm sure you all can relate if you're living on the East Coast. And again, there's going to be a presentation portion that Dr. Pan's going to do. And then we really want to open it up to your questions, and we'll discuss a patient case. And then at the end, we're really going to ask for volunteers for patient cases for the next few weeks. So again, this is our first module, so it's one of 4, and we'll be meeting on Tuesdays at the same time. And again, thanks so much for joining. I do want to just do some quick introductions. I won't call on everyone just to keep it moving. So if you do have excuse me, your camera on, I will ask that you just introduce yourself, tell us where you're practicing and what you do, and then we'll kind of move on. So I'll start with Dr. Pan. Dr. Pan, would you introduce yourself?
Hi, good afternoon. My name is Calvin Pan. I'm based in New York, NYU Langone. Have been in the liver or hepatology field for the last 30 years. And currently I'm focused on viral hepatitis, and hepatitis B is my passion. Welcome you all, and thank you for joining us today.
Thanks, Dr. Pan. And just a reminder, Faith might be reaching out to you via the chat. So just, we'll go through the chat features. I'm sure all of you know how Zoom chat works, but just in case, just because your screen name might not match your name. So we just want to make sure that we give you credit for attending this lecture. So we might be reaching out via the chat, and you could feel free to chat with Faith about that. And I'll mention that a couple other times. So I'm just going to go around just, in order of names that are popping up. Martha, nice to have you with us. Where are you practicing, and what's your specialty?
I'm in Tampa, Florida, and I'm a trauma nurse from Ryder Trauma. So I've seen a lot of variation, and now just slowing down to rehab at this point. But I am a Ryder Trauma nurse for 20 years.
And just a reminder, if you're not speaking, if you don't mind clicking your mute button, my team will just monitor that as well, just so we can hear everyone. Leslie, if you're able to introduce yourself.
I'm Leslie Eustason. I'm a retired registered nurse. I worked in public health and communicable disease, and followed and investigated hepatitis B cases. And so I'm just here. I was always very interested in hepatitis B cases. And when this popped up, I was very interested in joining the series.
All right. Thanks, Leslie. Nice to have you. Kenga, if you're able to unmute yourself. All right, we'll come back. Dr. Nunez.
Hello, how are you?
Wonderful. Thanks for joining.
I am from, my name is Byron Nunez. I am from Quito, Ecuador, South America. I'm infectious disease specialist and teacher of the Central University School of Medicine. My work this time is with patients HIV and co-infection with B hepatitis and other patients, especially in migrant patients with HBV and HBV patient chronicle. We have in this time around of 50 patients with HBV chronic infections. Nothing more. Thanks for your assistance.
Great. Thanks for joining us. And Aspelti, Lawrence?
Hi, I'm Dr. Lawrence. I'm from Puerto Rico. I work in Florida. I work in the correctional system in the Florida Department of Correction with a company called Centurion. We provide direct patient care to inmates with multiple diseases, infectious diseases, HIV, hepatitis C, B, and I'm very glad to be here.
Great. Happy you're here as well. And this is a really great number of people that we've got. We like to keep these groups small, but obviously not too small. So this is just the perfect number. So we hope that you will all be back next week when we talk to you then. And just one note, Dr. Carla Coffin was unable to be here today, but hopefully she will be here next week and she'll join Dr. Pan. All right, so I don't see anyone else pop up on camera, so I'm just going to go through excuse me, some introduction slides just so you can get a feel for what an echo is if you're not familiar with it before we move over to Dr. Pan's presentation. So required technology, if you're here, obviously you have the technology. So really you just need access to Zoom. You could be on your computer, your tablet, or your phone. Just note that some capabilities may be limited if you use your phones and tablets. So as I mentioned, we've got that chat feature. So if you can click, and I just lost my mouse, it's back. If you click the meeting chat, just let us know what type of machine you're using. Are you using a computer or a tablet, your phone? Curious to see what you're using. And thanks, Leslie. Leslie's already put that in the chat. Great, just want to make sure everyone can use that chat. And again, just look out for any notifications from my colleague Faith, just in case your name that's appearing in Zoom doesn't match the name that you may have registered for this program. Just want to make sure you got the credit for attending. So if you have any connection issues, you can contact us. So again, I'm Rachel and I'm joined by Faith and Jill, and we've got our email and our phone number here. Okay, the Project Echo story, if you're unfamiliar with Echo, so Project Echo was developed by Dr. Sanjeev Arora. Dr. Arora is a liver disease specialist at the University of New Mexico Health Sciences Center in Albuquerque. He was frustrated that he could only serve a fraction of the hepatitis C patients in the state, so he created a free educational model and mentored community providers across New Mexico in how to treat the condition. So the ECHO model is not a traditional telemedicine where the specialist assumes care of the patient, but instead it's telementoring. So it's a guided practice model where the participating clinician retains responsibility for managing the patient. The principles of Project Echo, as I mentioned at the beginning, we want this to be as interactive as possible. Obviously, you want to learn from Dr. Pan, but he wants to learn from you and hear about your experiences. So keep this interactive. There's going to be co-management of cases, peer-to-peer learning, and collaborative problem solving. All right, the program outline. So typically a 10 to 15-minute lecture at the start of each session. Today is a little bit different because we're doing introductions and we're doing these intro slides. And then there's a Q&A and then that patient case that I mentioned at the beginning. So just as to what's to come. So today we're going to be talking about screening and barriers. Then we'll move on to serology and management, current and emerging therapies, and then co-infection. So again, 4 modules for this. And I alluded to that case presentation format. So all of you are the spokes. We would love to have volunteers. We have a patient case form that I can share with you at the end. Of course, we can email it to you. It's on our website as well. So we would ask that one of you present your case. So one person each week. Include any lingering questions about managing your patient, but a good thing to keep in mind is that your case does not need to align with the lecture content. So if we're talking about serology, you don't have to be that specific. So the time is really just best used to help manage your patients. And then the hub team, that's Dr. Pan and Dr. Coffin when she's able to join, and possibly Dr. David Bernstein is able to join us as well. They will summarize the case, ask any clarifying questions, and ask for recommendations from your peers, so the rest of you, and make their recommendations and then summarize those. And thanks so much. I see some folks letting us know where your practice is in the chat. Keep those coming. All right, so meet and greet, we actually did that beforehand. But again, if you'd like to put it in the chat to keep things moving, definitely do that. So again, also in the chat, if you can let us know what you hope to bring to your practice after participating in this program. We always do a full outcomes report, and it's really incredible to see what our spokes, all of you, have learned from this, and really what you can take away from your practice. For your practice. And we'll be asking that question again at the end to see what you can take away. And last but not least, there's the echo clap, which is this. It started out when we did this actually pre-COVID, but since so many folks are muted, you can't hear the clapping, but you can see it. So that is our little meet and greet. Okay, so before we move over to Dr. Pan's presentation, we do have some pre-test questions. They are not scored. We just want to make sure that we measure the learnings, your knowledge retention. So definitely pay attention to the presentation, and then we'll ask these questions at the end. So I will administer those questions, and then we'll move on. So question 1, and again, if you're on a smaller device like an iPad or an iPhone or any other tablet, you might just have to scroll down. Prior to screening for hepatitis B, I educate my patients on the modes of transmission. So this is what you're doing currently. Would you say always, often, sometimes, rarely, or never? And then question 2, which of the following is the most common method of HBV transmission in Asian countries? And just an interesting tidbit about this program, we started out with an Echo HBV in Thailand, and then we moved over to China. Dr. Pan actually participated in that one. So it'll be interesting to see what knowledge was gained between all of those countries. So would you say mother to child transmission at birth, injection drug use, sexual activity, or traditional medicine like acupuncture? And then the last question. In your practice, approximately how many patients you see each week who are at risk for HBV? None, 1 to 10, 11 to 20, 21 to 30, 31 to 40, or more than 40? And I'll give everyone a moment to answer those. Thank you so much, everyone. And I will have Dr. Pan take it away, and then we'll move over to Q&A.
Wonderful. Thank you all for joining us this afternoon. So in the next 15 minutes, I'm going to go through some of the basics. I'm not going to teach you anything. I know many of you actually have some experience or even extensive experience with HBV. What I would like to do is try to set the stage for the discussion, focus on screenings and the barriers. Thanks. Wonderful. So let's move on. This is the education objective. We're going to learn HBV management and identify those patients that have a potential to get diagnosis and treatment. So let's start with the hepatitis B virus screening. Many of you may be aware of the new guideline, CDC guideline. We're going to get into it in a moment. So globally, about 300 million people with hepatitis B. In the United States, we have about 2 million people. Majority of them, actually, they are Asian descendants. And HBV not only is one of the most important infections globally, but the complication from HBV, including cirrhosis and liver cancer, actually is the major killer. Now, here on your right, you see a curve, and so in different countries, there are immigrants come to United States. Majority of the immigrants in the United States with HBV actually from China, and then the other Asian countries probably would take up 50% of the hepatitis B patients in the United States. So by the list from the high prevalence to the lowest, that's from China, Yunnan, Philippines, India, and Taiwan probably less, because Taiwan is one of the most national vaccination program pioneering in the world. So now many young people in Taiwan, they wouldn't have any infection at all. So here shows that in the United States and global elimination goal for the HBV set by WHO. Now we plan to have a global elimination goal, 90% reduction in the new infection by 2030. And at least we have to reduce 65% of the death from associated with HBV complications. But the goal is setting here is 90%, from 60 to 90%. We still have a long way to go if we don't screen those patients and treat them. So that's why it's so important. Today, we need to discuss the method or identify the at-risk population to do hepatitis B screening. Now, this is the transmission mode. As you have some pretext question asking about where patients would get hepatitis B. Now, in high prevalence area like Southeast Asia, majority of those patients with chronic hepatitis B infection actually get that from mother to child transmission. In United States, majority of those patients actually will get it through sexual transmission or IV drug use. Here is the risk of getting chronic infection by the age. This data actually highlight how important the early prevention of mother-to-child transmission could be the major step to reduce the new infection. If you look at babies get exposure to hepatitis B virus, under the age of 1 year, 90% of them actually develop chronic infection, versus in adulthood, only 5%. There are some misperceptions in terms of transmission. Some patients, they may worry about close contact through kissing, sneezing, or cough can transmit the disease. Actually, it's not. Now, breastfeeding have been studied. Actually, the virus in the breast milk is very low. And if the baby have been vaccinated, so breastfeeding is not the major concern to spread the virus. Now, of course, this is a bloodborne disease. There is no air, food, or water can transmit the disease unlike COVID. So here, again, showing the critical age to get chronic infection is less than age 5. So therefore, a newborn or infant vaccination with HBV vaccine, it really reduces the new infection and also have been shown to reduce the global HCC incidence. Here's the most important slide. CDC just issued a recommendation last month, require universal screening or Americans who, it doesn't matter whether they have been screened before or they have risk factor or not, they should at least get lifetime, one-time screening, just like hepatitis C. So now we are moving in national screening algorithm. Before we base on the risk-based screening, this is the history already. So we're going to talk a little bit about what you should do when you provide screening, including the vaccination part. Now, for patients at high risk, not only getting one-time screening, you may consider repeat screen those patients with risk. I heard that a couple of audiences here actually work with the high-risk population like prisoners or IV drug users. So for those patients or those individuals have high risk of reinfection, actually you can repeat the screening, particularly new listed here, like patient and multiple sexual partners, or they have IV drug users, and you could repeat the screening. What you should do when you screen the patients, the new CDC guideline actually recommend that you should provide vaccination at the same time, even though the screening test is still pending. So before, it's always a debate whether you should wait all the blood tests come back and showing patient is indicated, showing they didn't have any immunity to hepatitis B before you screen them. But now the new CDC guidelines support the left, the approach list on the left. You pair the testing with the vaccination. Give the patient the first vaccine when you screen, even though the screening result showing is hepatitis B infection already, you don't need to complete the whole 3 vaccination series. But in case they did not have any immunity, so actually you give the best opportunity to protect them. Now, there are some barriers why hepatitis B is still undertreated under screen disease. There are several misconceptions or barrier for the screening, because majority of the Asian Americans, they may be at risk for hepatitis B. So the cultural barriers still there. Many new immigrants, they may not know how to use American system, how to see doctors. So cultural barrier definitely have been identified. One of the issues hindering the screening, but the disease is per se is asymptomatic, and also there are some cultural belief or some misperception on the disease and worry about being isolated, being prejudiced. So many patients actually, they are afraid to move forward to find care provider for screening. The solutions, of course, with this new CDC guideline, we would expect that all the insurance should or will cover the screening and vaccination, and also provide appropriate patient education. You have to explain to your patient why it's so important to screen hepatitis B, because of complications and very bad consequences affecting the survival. So patient education is the key. Not only physician talking to patient, but healthcare providers or your assistant can explain to them the need, and the new CDC guideline, they should at least receive one-time screening. And that will change the outcome if they can be diagnosed and manage the disease in early stage. So there are some clinical barriers. For example, the treatment right now, there is no eradication, and a lot of patients confused. Even I got the diagnosis, are there any benefits? The answer is yes. The early treatment actually reduces cancer, the chance to develop cancer and cirrhosis. And also, right now, it's not like every state have the legislation or rule to mandate it. I know hepatitis C in New York is mandated by the regulation that you must do one-time screening. And I'm hoping that as the CDC new guideline and many state legislators will come out with a solution or regulation to mandate hepatitis B screening. So some of the solutions proposed here, you should update your screening criteria based on the new CDC guidelines. Screen everybody is very easy now. You can even identify those patients from the EMR system. Whoever has been screened, they should receive at least one-time screening. And we're going to talk about how to interpret the serology in your next module, module 2, and subsequently the treatment and management in module 3 and 4. So there are some other help that can be implemented, identify HBV patients, assess the screening routine care. For example, if in your institution, if we can implement the reminder in the EMR through the systemic management of screening risk, that perhaps can enhance the rate of screening. So I think with that, I would open to the floor for the discussion. Welcome you to bring any cases or any experience or comments.
Great. And again, we understand some of you are in clinic, you're at your office, you're unable to turn your cameras on, but if you are, we'd love to see you. So we do have some questions that are coming into the chat, but if you'd like to ask them, feel free to take yourself off mute and do so. The first question is, Dr. Pan, how long of intervals between screening?
This is a great question. I would presume that you asked for patients who have who have been at risk for reinfection. Is it a question addressing, what's the interval between two screen?
Yes,
in my practice,
I
I'm
made
sorry.
the question, doctor. Yes, it's like we do have baseline screening for incarcerated patients. Like you said, they're in a high risk, but we do have problems even inside prison, with the illicit drug use, men that have sex with men. So what will be the time frame that we should, do the screening? What's the important time frame?
Yeah, that's a great question. Now, I guess, I interpret your question right. It's talking about repeat screening. Many patients, actually, they don't need a repeat screening if they're not in high risk, right? If you're seeing a kid in the community and just one-time screening and document it. Now, for your population or any high-risk population like MSM or they're actively using drug or in prison, so the data suggests that to identify the chronic infection, you need 6 months, right? So shorter than 6 months from the last screening, it doesn't make a lot of sense because, even the patient may have another exposure. If they want to develop chronic infection, it could take 6 months later on, you can declare that because many patients, they can clear that before 6 months. So we are screening not for acute infection unless they have symptoms. We're screening for chronic infection. So I wouldn't do less shorter than 6 months. But I think in high-risk patient, I don't want to wait for years. I think it makes sense once a year screening, but not shorter than 6 months. It will be supported by most of the natural history studies. Thank you.
Thanks, Dr. Lawrence, for your question. I have another question in the chat. In a significant proportion of patients, we don't know how they acquired CHB. What are the possible reasons?
Significant portion of patients, you couldn't find where they got the HBV. I think they are from vertical transmission base. And if you're talking about Asian population or high prevalence area, but in Western country, I think either through sexual or IV drug or contaminated blood, there have been documented even allogeneic reason for dental work or not using disposable needles. Those allogeneic transmission is possible. If patients have any blood product before like blood transfusion, it could be it. So bottom line is, it may not be critical where they got this. Bottom line is you screen them and identify them and treat them. Yes, I agree with you. Oftentimes, patients even show up in my office and say, "Hey, doc, I don't know where I got this." When we make a diagnosis, that's true. But if you want me to guess, and I'll base on where they're coming from. If they're coming from, they born in the area more than 2% of hepatitis B, chances are they probably got it from their family.
Thanks, Dr. Pan. And I'm getting some questions directed to me in the chat, but I'll just put them in the chat so everyone can see them. The first question is, why should we test all adults for hepatitis B if we know they are vaccinated?
That's a wonderful question. So I guess this question have two folds. One is, if they vaccinated, should they get tested again? And secondary is why we want to just focus on the adult. the current CDC guideline test every adult is because there might be much lower prevalence rate in the younger people, since they have all the national programs, particularly in developed countries, unless they're immigrants. You don't know where they're coming from. In United States, all baby get vaccinated at birth, and then they complete their vaccination within 1 year of age. And therefore, adult population probably have highest incidence than the infants. And this is across the board. It doesn't matter which country you go to. Any places that start with a vaccination program, they have a very low incidence rate for those kids, less than 2% in China. Now there's less than 1% if they're age less than 5-year-old. Versus the adult population is 6.7%. In the US, it's about 2%. The kids are much less. So another question, the second fold is, should we still test them even they get vaccinated? The answer is yes, because oftentimes the universal vaccination policy would not require testing. So many patients actually, they got hepatitis B, they still get vaccinated. And then you miss the boat, you miss the diagnosis. And the next thing you know is in 20 to 30 years, they develop liver cancer or cirrhosis, because chronic hepatitis B infection, the lifetime risk to develop cancer or cirrhosis is 35 to 40%.
Thanks, Dr. Pan. And yeah, that's a question I was just going to ask you. So thanks for answering that one. Another question, I'll put it in the chat so everyone can see it. In the US, how likely is it that someone who has acute hepatitis B from injection drug use will go on to develop chronic hepatitis B?
Actually, we have the slide we just went through. The differences between the adult population and the early age to get exposed to hepatitis B is the chances develop chronic infection. In adult population, age older than 18, the chances are very small, 5%. But still, you need to pay attention to this, screen that 5% and don't let them get into the cancer. But the answer is yes, they are doing much better. If they get exposed when their immune function is developed, even they never receive any vaccine, the chances to get chronic infection after exposure is 5%. If they got vaccinated, actually it's less than 1 in 1,000 chance they can break through the vaccine. So it's a huge difference.
Okay, and I see some questions just came through. I'm just going to put this other one so we can get to this first. Is reflex testing as good as the new triple panel test?
The new CDC guideline actually recommend the 3-panel test, because it will give you the opportunity to identify patients who may need vaccination now, right? So I know you are moving ahead of our schedule. Actually, in the next module, we're going to talk about how to interpret. So since you bring this up, let me just briefly orientate the whole group and to the direction of interpretation. So the triple panel you asked is including the hepatitis B surface antigen, core antibody, and surface antibody. And what does it mean? These are 3 proteins made by the virus, actually showing that whether the virus is actively replicating, that's the surface antigen. Without that replication, patient, even they don't get the infection, they could have the antibody by getting the vaccination, right? Stimulate them to get the antibody, just like you got COVID, antibody doesn't mean you got COVID. So the antibody is a good thing. But if the core antibody, the core protein antibody is a bad thing, that means they have a lower level of replication, right? But why there are 2 antibody doesn't mean it's the same, because the surface antigen if they stimulate the body, develop antibody against the virus, that's protective. But the core antibody is not protective. So the core antibody indicate the virus might be still in your body. So on your module 4, we probably talk about special population. I know some of you are very actively engaging in hepatitis C infection. So Hep C patients, when they have a core antibody of hepatitis B, they can reactivate the disease when you get the C treatment. So just make the things more simple for you to apply in your clinical setting. The surface antigen is a bad thing. It's active disease, chronic infection. Surface antibody is good stuff. It protects you. And the core is still infected, but at a lower level. So this new CDC guideline require you to order 3, all of them. And then you go from there. If actively infection, that means surface antigen positive, you move on the further evaluation whether the patient should get treated or observed. If everything is negative, but only the antibody, surface antibody positive, that's a good thing. That means patient got the vaccine before, right? There is a 0 infection. But if everything negative, except the core antibody positive, that means the patient still have a chance of chronic infection in a lower level of application. Of course, you can argue it could be a false positive and you still want to give them vaccine. So that's a different story. I think it's a little bit advanced for today's talk, but I'm glad to answer that since you're curious.
Thanks, Dr. Pan. How often should testing be done for people with continued possible exposure, someone like MSM?
I guess, the other doctor just asked that question because I think he is taking care of prisoners. I think it doesn't matter prisoners or MSM or actively IV drug users. They all consider a high-risk group for reinfection. So I would recommend the same algorithm. There is no very set stone rule from CDC guideline and say how often. I just, based on the clinical data and explain my approach, is I will recommend at least 6 months from the last screening. Between 6 months to 12 months should get repeat screening if you consider they're high risk.
Great. Thanks, Dr. Pan. Any other questions? And feel free to come off mute, unmute yourself, and you can turn your camera on as well. Great questions coming in for Dr. Pan.
Can I ask?
Sure, go ahead.
Okay, sorry if I put on my camera, then my connection will be really bad. So the risk of mother to child transmission in E antigen positive versus in E antigen negative mothers, vertical transmission.
Yes, let me repeat the question and see if I captured that right. So you're asking, are there any difference between E antigen positive patients and E antigen negative patient in terms of transmittability, right?
Yes, yes.
So let's talk about 2 major roles of transmission. One is mother to child transmission. In that content, it matters. E positive mothers will be more capable to transmit the disease to their baby compared to E antigen negative mothers, because the major difference is the E antigen positive, they can replicate the virus in a higher level. So the higher the viral load, the easier to break through the immunoprophylaxis for the infant. That means, they would get the immunoglobulin and vaccine. It will break through very easy, about 10%, 20% of time. Now, in terms of horizontal transmission, that means, adult to adult or through the risk behavior like IV drug, MSM, or sexual transmitted disease. It really depends on the E antigen levels, E antigen's patient's viral level. Same concept apply. The higher level of the E of the hepatitis B patients, the higher viremic level, the easier to transmit the disease. But the differences between mother and the other adults is most mother, they are young, right? It's hard to imagine a 45 to 50-year-old female can still have a better chance than a 20-year-old to have a baby. So when the mother is young and E antigen positive young patient, they often have a viral load over 1 million. So therefore, definitely, E antigen positive mother for sure. Now, if you're talking about adult between adult transmission, then it really depends on the age of that adult. If you're MSM, the one that who had the hepatitis B is age 50, even his E antigen negative, he probably at the end of the E antigen stage of burnout, the viral slowed down already. So sometimes in elderly people, their E antigen positive negative doesn't necessarily to indicate the level of viremia. Some of the E antigen negative have higher viremic level than those with E antigen positive. So I cannot say for sure, it depends. But for mother to child transmission, for sure. E antigen positive actually could be a surrogate to label those mother of high risk of transmission. Would that answer your question?
Yes, may I ask one more question?
Sure.
Is it possible for someone to have surface antibody, to be surface antibody positive and at the same time core antibody positive? Both surface antibody and core antibody at the same time, is it possible to have someone?
Yes. So both surface antibody and core antibody positive actually is oftentimes is in two scenarios. One is, we mentioned before, if you have core positive, that means you still have virus in the body. It just, very lower level of replicating. So oftentimes one scenario is patient have either spontaneous immune clearance of the virus to the level that the virus suppressed to a very low replication stage. Then the body start to develop antibody against the virus, but not 100% eradicate. So we are saying this condition called clinical cure, right? This stage could be spontaneously happen in very few patients, but nowadays many antiviral therapy on your module 3 or module 4, we can see that we can get to that stage. That's a good thing. When patients get into surface antibody positive, even they still have core antibody, they have much, much less chance to get cancer and cirrhosis. All right. Now, another possibility, another scenario would be the core antibody was false positive. There are many viral proteins, they could stimulate the core antibody. Just like if you recall hepatitis C, you have hepatitis C antibody positive, but always test RNA negative. They have autoimmune disease and can trigger the hepatitis C antibody positive. So about 10-20% of those patients, they might have core antibody positive, but they don't have the virus. So in this scenario, they have core antibody false positive, and their surface antibody could be from the vaccine. That could be another scenario, even though it's rare. So in clinical setting, we treat core antibody and surface antibody positive patients still consider have 60–70% of chance they are infected. They just get into a much better immune control stage.
Thanks, Dr. Pan, and thanks for everyone for your questions. We do have time to go over a patient case, and Martha, if we have time, we'll get to your question that you just asked in the chat. Dr. Pan, I'm happy to share my slides if you'd like.
That's great.
Okay. Okay, and I don't want to give you a preview of what's to come, so we're just going to look at this case one for this first module. So Dr. Pan, if you want to give a, read aloud this slide and ask that question.
Okay, so this case actually was a real patient in China, presented by one of the Chinese doctors. But in case any of you in the audience, you bring in the case, feel free to verbally present to us, and then we can work on that. Now, since we have enough time, and I would bring this case up to you and see what you think. A 65-year-old male, a patient of chronic hepatitis B. He was treated with antiviral therapy with lamivudine, which is the most earlier Navarro in 2010, because he had a persistent elevation of ALT. Now, 8 years later, a regular follow-up found that the hepatitis B virus actually still 5 logs, almost 6 logs. That means close to a million, 1 million international unit. And if you were his primary doctor, what would you suggest based on this blood test report?
Any takers?
Can I?
Oh, go ahead. Sure.
Yeah, resistance to lamivudine.
Yeah, that's a good suggestion. What are the other possible explanations?
I will say that Shantae in the chat said resistant to lamivudine change treatment.
Right. Any other suggestions? Wonderful.
Yep.
So Chante actually proposed non-compliance. Comorbidity, no. This is a very young guy, and he is a basketball player, have 2 kids, healthy. Reinfection, well, he doesn't have any risk factors. He's a regular guy with 2 kids that stayed with his wife, and his wife was negative and got vaccinated. Any other possibility? We got 2 proposed scenario. One is non-compliance. Another one is lamivudine resistance. All right. So I think those are great answers. I will throw in a third one, but don't get surprised. It could be a lab error. HBV DNA could be contaminated. So if I want to put the money on, number 1 would be non-compliance. There are actually studies showing that in hepatitis B patient viral rebound, the number 1 cause is non-compliance. It take up to 60% of those patients have viral rebound is because they forgot to take the pill. And secondary for second-line treatment like lamivudine, talbivudine, or even entecavir, they may be able to develop antiviral resistance. So antiviral resistance is one of the consideration. And the third one would be the lab error. So let's go by the managed algorithm. The first thing is easy, is try to ask the patient, are you taking the pill? Because you're not going to spend another couple $100 to test the DNA. Well, if you confirm patient is compliant, and definitely the second step is retest the HBV DNA and add on the resistant test, right? You need to send another one. Well, if it comes back, HBV DNA is still there, and they should be able to see what resistant is. If the HBV DNA is negative, come back the second time, it could be contaminated. So two stepwise. One is try to dig out if patient's non-compliant. Another way that some stupid things that I know is sometimes I call the wife and ask for if a patient taking it, show me the bottle if they have any pill left. Occasionally my patient lying to me. We just don't like to take the medication for so many years, and they're feeling okay. And they think that skipping a pill is nothing would happen. We still have some time. Can we take more questions? I think somebody asked a question before.
And I'm muted. Let's take Martha's question, and then we've got a few minutes left for the post-test polling. So Martha asked, interesting question, for travelers to Asian countries, what are the chief risks and what can they do to protect themselves?
My question about traveling is because there are a lot of Asian countries that do have active HBV, and in going through foods and all of the different cities that are located on water, like Bangkok, and going to Thailand and going to Taiwan, are there any chances of HBV infections moving through foods and other transmission modes?
Thank you for the question. I think it doesn't matter how high the prevalence is. It would not change the transmission mode. It's mainly blood-borne disease and the food or air or the other contacts, unless it's contaminated body fluid, there is no theoretical risk or any practical reason why they get infected. They mainly get infected with hepatitis A.
Yes, yes. Yeah, hepatitis A was what I would imagine. I had someone ask me that question recently, and so I thought I'd pass it along.
Right, not for B though, but you can explain to them they may have a high chance to get Hep A. We do recommend all the travelers to high-risk area for hepatitis A or B to get vaccinated.
Okay, that's fair. And my second question was, is there contamination if albumin and PPF have been not heat treated to inactivate a hepatitis virus vaccine? Can it be transmitted through those factors, especially for people that are getting albumin therapy to correct low albumin deficiencies because they have chronic liver disease?
The answer is yes, because the hepatitis B virus actually can be very tough to use heat or the other methods to clean. So I wouldn't, if the blood product have been contaminated or have the potential to get contaminated, definitely should be removed from the practice. Because before there was a study showing that when they use a non-disposable needle, even the blood clot inside the needle have been cooked, right? They use the metal needle, put it in hot water and cooked it, and they still transmit the hepatitis B disease through the contaminated needles. Even they cook for 10 minutes for that needle.
Okay, fair enough. Thank you.
Thanks, Dr. Pan. Thanks, Martha. All right, so really great questions. Let's move on to our post-test poll. And then after that, Faith will put the link to the evaluation in the chat. If you're looking for CME or nursing credit, that's how you can claim that. Just make sure that you're logged in with your DKB Med email address when you do that. And if you have any questions, we're also going to email a link to the slides that Dr. Pan presented and a link to the evaluation, so you won't miss that. All right, so let's launch that post-test poll. All right, so these questions should look similar. As a result of this activity, how confident are you now in overcoming stigma regarding hepatitis B in your practice? Hopefully you're more confident, but we have a few more weeks. Much more confident, moderately confident, somewhat more confident, or not more confident? And then you'll just need to scroll down. Question 2, which of the following is the most common method of hepatitis B transmission in Asian countries? Mother-to-child transmission at birth, injection drug use, sexual activity, or traditional medicine? Give everyone a moment to answer those. And Faith, you can put the link in the chat to the evaluation. And before we go, thanks, Faith, I do want to just share that case presentation, that form that I alluded to before. So I will do that in just a moment. Okay, I'm going to end the poll. And again, we'll have some more time in the coming weeks for questions and answers and the case presentation, since we did a little more of an intro today. Okay, let's look at our results. So it looks like, and hopefully, Faith, you're able to see this? Okay, great. Looks like people are more confident, which is wonderful. Dr. Pan, what's the correct answer here? 75% said mother-to-child transmission at birth.
Oh, thank you. I will go with the majority. Indeed, the mother-to-child is the correct answer.
Great. Definitely all paying attention. All right, and as promised, let me just share this form with all of you. And I will ask for any volunteers. I won't put anyone on the spot. I won't call anyone out. But if you are interested, just let us know in the chat, or you can send us an email. Again, you'll get an email with the link to the evaluation in the slides. So this is the form that we would ask for you to fill out as much as you can. Interested in, obviously, the patient's age, their race, medical diagnoses, things like that. And then we've got some other information here. We would just ask that you share this with us prior to, so probably, later in the week before, so we can get this to Dr. Pan so he can review it prior to you presenting it. All right. So if there are any takers, feel free to put that in the chat. Want to keep this as interactive and really hear from you and hear about your patients that you're treating. All right, so with that, thank you everyone so much. Special thanks to you, Dr. Pan. We'll see everyone next week at the same time. So it's Tuesdays at 12 Eastern. Don't forget our echo clap. Thank you so much, everyone, and we will see you next week. Take care.
Thank you all. Have a good one.
Thank you.